Laura Hinz, who's here to talk about osteoporosis. She is an endocrinologist at the U of C. She went to medical school at Western University back when it was known as University of Western Ontario, and did a residency at the U of C. She's completed a Master's of Medical Education at the U of C. She's Program Director for Adult Endocrinology and Metabolism Program and the lead of the Endocrine Transplant Program. She has a special interest in osteoporosis and metabolic bone disease. She has much behind her, I think is the bottom line there. She's married to a rheumatologist, has 2 little girls, loves ballet, and thinks great shoes are the keys to happiness, so please notice her shoes as we welcome Dr. Hinz.
All right, good morning, everybody. It is an absolute pleasure to be here today to talk to you about one of my most favorite topics. It's a special day for me as well. My daughters are in the front row here, so we got to start the women empowerment early. And also thank you to my husband, who lives in a very sparkly household and is the kind of ally that we all need. So thank you for them to coming. All right, so let's get started here. Green button ahead, they tell me. All right, there we go. All right, I have nothing relevant to disclose. No one gives me money. So let's start off. What is osteoporosis? So at the end of the day, osteoporosis is an increased risk of fracture. This is why we care about it. We're worried about broken bones. And it happens because our bones are lacking strength. Many times when people come to my osteoporosis clinic, they start telling me about pain in their elbows, pain in their feet. And I say, well, you actually need to go see my husband, the rheumatologist, because I know nothing about that. And then they're sad. So the issue is osteoporosis doesn't have symptoms. It's not pain, it's not joint pain, it's often a silent disease until we end up with fractures. And that's why we're here today, to figure out, well, how can we get on top of this before we have trouble? The other thing people often tell me is, well, I don't need your medicines, I have calcium and vitamin D. That's fantastic, that's a really good start, but that's preventing something else. That's preventing osteomalacia, which is softening of the bones. The two can often coexist, but they are still separate entities. When we think about bone strength, the first thing that often comes to mind is bone density, because that's one of our very best tools that we have to figure out, are we going to end up with trouble? The issue is that it's only one of the many things that contribute to your bone strength. So yes, it's important how dense your bones are, but we also know the shape of your bones is important. What is the structure? More and more we're getting interested in the microarchitecture. So when we look really closely at those bones, how are they put together? The mineralization is important. In order for your bones to be nice and hard, we need lots of calcium, phosphate, vitamin D. And then a really important concept is turnover. So we often think of our bones as being the same all the time, but they're not. We're always breaking down old bone and building up new bone. My girls are still growing. Their balance here is shifted. They have more formation than resorption. That goes on until about our mid to late 20s. And then things are in a nice balance through our 20s, 30s, and 40s. So the resorption and formation are nicely balanced. Estrogen acts like fertilizer for the bones. So when it comes time for menopause, we see that rapid decrease in estrogen and the balance shifts once more, and this time in a direction that we don't really want. So we're seeing more resorption than formation. So that's why we start to think of osteoporosis as a disorder of postmenopausal women, because that's when we really start to see that shift towards bone breakdown. Why is this important? This is actually a slide from a few years ago that I didn't want to update because the stats were going to be even sadder. But osteoporosis is incredibly common. So there are millions of people in Canada with osteoporosis. But I want to draw your attention to the bottom number here. So 21% of people with osteoporosis will fracture. But I told you that that's what I care about. I care about fractures. So ultimately, we're putting this label on a lot of people who may or may not have the outcome of interest. So we need to do better. We need to figure out who is at high risk of having a fracture. And that's where I want to start shifting our thinking. Rather than a black and white dichotomous diagnosis, do you have osteoporosis, yes or no, your doctors are going to start to think about where do you fall on a risk spectrum. Because then obviously we're going to treat people who are at high risk very differently than we do people who are at low risk. Many times people think, well, this isn't all that important. I broke my arm when I was 8, people signed my cast, it was really fun. That's not the kind of fracture I'm worried about. I'm worried about hip fractures, spine fractures. These are a big deal. So in people who break a hip, 50% of them don't walk independently again. Think about what that would do to your daily activities. 25% of people don't go home. They end up going to long-term care. And this is hugely costly. They spend $17 billion a year in the States on hip fracture care. So we need to do something about this. Okay, I know I speak really quickly, so if I've lost you somewhere along the way, these pink slides are a summary of what I've just rambled about. So osteoporosis is an increased risk of fracture or broken bones. It's not the same as arthritis. It's not the same as a nutrient deficiency, and it's common and serious. Okay, so how do I know if I have this? Anytime I give a talk, I like to know which celebrity has the disease I'm talking about. So imagine my surprise when I Googled which celebrity has osteoporosis, and my buddy, the founder of Goop, Gwyneth Paltrow, came up. Actually, I was really delighted that she was the face that the internet provided for me, because this is a really nice example that most of the time when we look at people, we don't know that they have osteoporosis. Like I said, this is not your elbow pain, and if you haven't had fractures, you're probably not going to look any different from someone who doesn't have osteoporosis. So now we're seeing that, I can't just look at someone and know that they have it, so I need to make sure that I have different and better tools. If you haven't noticed already, I really like to talk, and that's what endocrinologists do. We talk to people. So we like to know your story. So have you had broken bones, especially in adulthood? So we worry particularly about fractures that happen after the age of 40, and especially if they happen with what we call a low trauma mechanism. So if your activity involved a waiver, you were skydiving, you were horseback riding, probably not interested, but it's those fractures where we wouldn't expect them to happen. When we break bones in our spine, they don't crack in half like chalk, they squash. So if you're noticing that you're losing height, one of the reasons for that may be fractures in the vertebrae, so we really pay attention to height loss. Family history is incredibly important as well, so know if anyone in your family has had hip fractures, and then high-risk conditions I'm going to talk about in a second. Because my physical exam is not that helpful, my rheumatology husband often says, you don't touch people. I don't. I talk to people. I do tests. So these tests are very important for us. So what are some of these conditions that put us at risk of osteoporosis? Well, there's other hormone conditions. So in people who have untreated overactive thyroid problems, we talked about estrogen being that fertilizer for the bones. So in people who go through menopause early and have less estrogen, we worry about that. There's a lot of things in our lifestyle that can contribute as well. So if we're not getting enough calories and enough calcium, enough vitamin D, that can be a problem. Many medications can play a role. The biggest offender is going to be steroids. And then there's a bunch of other medical problems that can contribute. So kidney disease, liver disease, rheumatoid arthritis. But the biggest thing at the end of the day is genetics. So many times people are really sad to be in my clinic. They say, well, Dr. Hinz, I did everything right. Why do I have osteoporosis? I really like analogies, so I'm going to give you a couple of analogies today. So it's almost like saying, well, Dr. Hinz, I stretched and I ate well. Why aren't I tall like you? Well, my parents are 6 feet tall. So that's what my genetics are saying. If your parents are not 6 feet tall, you were never going to get there, regardless of what you were doing. And the same thing with osteoporosis. That's not to say that all of those good choices you're making are for naught. Those are still playing a really, really big role. Maybe that prevented you from having 3 fractures and instead you just had 1. But at the end of the day, there are things that are outside of our control. So bone density, this is one of our biggest tools that we use because you may be walking around looking like Gwyneth Paltrow and I want to know, what are your bones like? So this is where a bone density is helpful. A bone density is an X-ray. It takes a picture of your spine and of your hip, and we figure out how hard are those bones. We do it in everybody who's 70, regardless of what their risks or their story are. And in younger people, we want to see that there's more risks to it. We don't do bone density scans in younger individuals. And many times people say, well, I want to be proactive. I want to know what's coming for me in my future. I want to get on top of this now. I actually had a phone call from a physician friend the other day to say, hey, Laura, should I pay for DEXA? And my answer was absolutely not. Go buy yourself some heavier dumbbells. Why? Why am I saying that? Well, bone density is there to predict fracture risk, and it does that decently well in older people. In younger people, that link isn't as solid. So again, here's our second analogy of the day. It's like packing for a trip that's going to happen in 6 months. And in doing so, that's great. We're being on top of things. But if you look at the weather report of your destination today, that's probably not going to be helpful. And that's kind of what we're doing here. So in Alberta, we actually cannot order a bone density on people under the age of 50. You're obviously welcome to spend your money in whatever way you want to. I will not be spending my money on that. I'm going to be buying those heavier dumbbells. Okay, well, that's not really helpful. I want to know stuff. Okay, well, let's use a different tool. So this is a really nice tool called FRAX, the Fracture Risk Assessment Tool. So this is put out by the World Health Organization, and it helps to predict what is your risk of having a fracture. I really, really like this tool because we talked about this concept of rather than saying yes or no, I have osteoporosis, but where do you fall on that risk spectrum? So this is a tool that you can run for yourself. You'll notice that question 12 is a bone density, but you can leave it blank and it runs just as well. So you answer a few yes or no questions, and then it tells you what is your risk of having a fracture in the next 10 years. Ultimately, my job is to bring all of that information together. So people who fall on that high risk end of the spectrum are those who have a low bone density, if I happen to have that available. If that FRAX number is greater than 15 to 20%, obviously if they've broken those big serious bones, those are the folks who come to my clinic and we talk about medicine. I suspect that most people in this room today are going to fall on this other side, this not high risk, in which case we don't use medications, but we can use other things. So what are those other things? I have the most wonderful nurse in my transplant clinic, and she always tells me that I prescribe cheese and jumping. That's exactly what I'm doing. So cheese and jumping for all. What do I mean by that? Excellent. So cheese. So it doesn't have to be cheese. We're looking for dietary calcium. So premenopausal women need about 1,000 milligrams of calcium a day. Postmenopausal women need 1,200 milligrams. Well, that's lovely. What does that look like? The average balanced diet has about 300 milligrams from bits and pieces here and there. Every serving of dairy is going to be another 300 milligrams. So I had my latte this morning. I'm going to have some cheese with my dinner tonight. I'm going to eat fairly well today. That's pretty darn close to 1,000 milligrams. What about calcium supplements? Well, in some people, we try and get it through the diet wherever possible. There is some suggestion that calcium supplements increase the risk of heart disease, and it's also possible to have too much calcium, so more is not better. So if you're getting enough calcium through your diet, don't take a supplement. In folks that don't include dairy or they have other restrictions around their diet, we may not be able to get there, and that's okay. Those are the folks that we can use supplements for, but we don't want to go in excess of that 1,000 for premenopausal, 1,200 milligrams for postmenopausal. What is that jumping part? Well, this is exercise, and I just made some awesome new friends backstage who are going to talk to you more about exercise, so I'm really excited to hear what they have to say. There's a few types of exercise that I'm particularly interested in. So we've always talked about weight-bearing exercise when it comes to osteoporosis, and people often come in and they say, well, I don't want to do weightlifting. I'm not talking about weightlifting. So we're just meaning supporting the weight of your body. So walking, running, dancing, whatever it is that brings you joy. The second category is strength training. So we know if we lose muscle, we lose bones. We really want to hang on to that strength. So that's why I told my friend to buy dumbbells and not a bone density scan, because that's where we were going to end up anyways. The third category is balance training. So we know that most fractures happen from falls. So if we can keep a nice strong core, number one, we're keeping pressure off of our spines, and number two, we're preventing that falls risk as well. The fourth category is impact training. So this came out in the latest Osteoporosis Canada guidelines, and I was a little confused about what this meant. I had the opportunity to chat with the lady who wrote this section, and she said, you know, it's impact training. So it's like Moira Rose folded in. But it is jumping at the end of the day. Not every body is able to jump. So if that's not for you, then things like walking on a hard surface are what we're looking for. And then finally, we need vitamin D. So again, vitamin D is something that comes from the sun, but just where our latitude is at in Canada, you would need to be naked outside for unsociable amounts of time to get enough. So most people need a vitamin D supplement. How much vitamin D do you need? That's an excellent question. Ask 10 different doctors, you're going to get 10 different answers. So somewhere between 400 and 4,000 units is going to be good for the vast majority of people. But we know that more is not better, and in fact, more is harmful. Vitamin D is a fat-soluble vitamin, so unlike your vitamin Bs and Cs that if you take too much, you've just made really expensive urine, this actually stays in your body and can do harm. There's some suggestion that excess vitamin D can actually increase your fracture risk as well. So I know we're all trying to be proactive about our health, but more is not better. All right, there's a lot of talking. So we're going to prevent osteoporosis with dietary calcium, supplemental vitamin D, and weight-bearing exercise. I'm going to show you this slide one more time because even if we're doing all of this, many times people come to my clinic and they have osteoporosis and they're really upset because they said, but I came to your talk and I listened to all the things and I did it and I'm still here. Genetics, right? Genetics is a powerful thing. So what am I doing in my clinic? I'm just going to give you a very brief overview of the types of medicines that we have available. On the far right here, we have hormone replacement therapy. So I've mentioned a few times about estrogen being that fertilizer for the bones. So obviously when it goes away around the time of menopause, that's a problem. So in some people, we will give that hormone back. This is going to be an individualized conversation with your doctor to figure out, is that the right path for you? At the beginning, we had that teeter-totter where we talked about resorption or breakdown of the bones and formation or building of the bones. And those are really the two main categories. I know there's a few medical student buddies in here. We learned about this. So this is what we're doing. We've got one category of medications that stops that bone breakdown. These are our anti-resorptives. This is the vast majority of what we start with in osteoporosis medication. The second category is anabolics, and these build up bone. You're probably thinking, well, that sounds better, let's do that. They're very expensive. We're talking on the order of $15,000 to $20,000 for a course of therapy, and then unfortunately they're not covered by Blue Cross at this time. They're also injectable medications. So we tend to use these for people who fall on that very far end of the risk spectrum. So especially if they've had vertebral fractures or multiple vertebral fractures, if their bone density is incredibly low, they're really on that far end of the spectrum. That's all I'm going to say about medications today, other than to know that this is an individualized conversation with your own doctor to figure out what's going to be the best fit for you. People sometimes are nervous because there's a lot of information online about, well, this is going to give you brittle bones. Yes and no. There's a nugget of truth in that. The main medicines that we use are the ones that stop bone breakdown. That's a good thing. It's normal to lose about 1% to 2% of your bone mass per year. So if we slow down that process, that's actually a really big win. But the problem is that life is traumatic. There's always little cracks and microtraumas that happen to the bones. And what the body does is break down that old bone and lay down new bone. So if you've been on these medicines for a very long time and we've completely suppressed those bone breakdown guys, then obviously that leads to trouble. And it's for this reason that these medicines are not lifelong medications. So if we use them properly and safely, then this can be a very, very good choice. So don't listen to everything that's on the internet. All right, so in our last few minutes, I just want to talk about why is this so challenging? Why is osteoporosis one of the hardest things that I do in my clinic? Well, it's because we're preventing future problems. This is not a problem that you have today. If you came to me with your sore elbow and I gave you a medicine to take away the pain, you'd be delighted to take it. That's not what I'm offering. I'm offering you a pill with a lot of instructions to it that's going to prevent problems down the road. So it's almost like buying insurance, and that's very hard for us to do. The other thing that's tough is you'll notice that I really didn't give you any black and white information today. I gave you a lot of it depends, individualized, talk to your doctor, we're not sure. So there's a lot of uncertainty in this, especially when we're dealing with risk. We're trying to figure out, well, what is the risk of doing something versus not doing something? And that's very challenging. I'm a huge Wicked fan. Little one had a Wicked themed party. It was awesome. For those of you who are not familiar with this movie, basically it's the backstory of the Wizard of Oz. And the Wicked Witch is not in fact wicked, and she's the only one in the whole movie who has any sort of magical powers, but the people don't like her, so they don't believe her. The scene that I'm showing you here is the wizard says, you know what, I know that I don't have any magic, I don't have any powers, but I'm not going to tell the people because they don't want to hear it. They like to know that there's magic. So there's a line in one of the songs that says, there are precious few with moral ambiguities, so we act as though they don't exist. And you'll find a lot of this in the wellness spheres and online and on Instagram and TikTok of people saying, well, Dr. Hinz was super wishy-washy. That's boring. Let me give you some certainty in this. But unfortunately, that's the wizard. So there's a bunch of magic wands out there that I just want to make sure that we have the ability to think critically about. One of the words that really triggers me is natural. So it's natural to lose bone. You are going to lose 1% to 2% of your bone mass per year. So anytime people tell me that they have natural therapies, no, I'm going to be supernatural, right? This is what's naturally going to happen to my body. I also worry about the word cure because this is a chronic condition. This is something that we expect if you live long enough, everyone's going to develop. There isn't a cure, but there's ways that we can manage and mitigate that risk. So those words always get me a little bit leery. Vitamin K2 probably doesn't belong completely on this list, but right now it is not in any of the guidelines. So it's not a standard recommendation. When you come to my clinic, I will talk to you about cheese and jumping. I'll talk to you about vitamin D. We may talk about those medications, but we won't talk about K2 because there just isn't enough hard and fast data to say that, yes, it's going to prevent fractures or no, it isn't. We also know that it's probably not causing harm. So in people who come to me and they're already taking it, I don't fight them on it. We do get it in our diet. So in things like egg yolks, we do get some vitamin K2 there. We already talked about that very high dose vitamin D. That's not great either. So there's many folks out there saying, oh, the secrets your doctors don't want you to know. I must not be on that mailing list because I'm going to tell you all the things that I know. Things like vibration plates, again, maybe it's helpful, but we just don't have the study behind it and we have limited time. So if I have half an hour in my day, I'm going to get a lot of muscular benefits, a lot of cardiovascular benefits, a lot of mental health benefits from doing a workout. Am I going to help my bones by spending that 30 minutes on a vibration plate? I might. I don't have data to support or refute that, but I definitely know that exercise is going to be helpful. So if I have limited time, I'm going to put it there for now. Testosterone. So again, this is a big topic when we're thinking about menopausal care. Even men, the effect on their bones is because testosterone is converted to estrogen in the body. So there are very few testosterone receptors on our bone, and there is no evidence that testosterone therapy is going to fix your bones. I'm also really, really nervous when things come with a very big price tag. I think the worst that I saw in the last couple of months was a $12,000 course. All the secrets your doctor doesn't want you to know. Well, there you go. I just saved you $12,000. You're welcome. All right, so I just took away all of those beautiful magic wands. What am I going to give you in return? Well, let's use some things that are real. So we're going to aim for that dietary calcium. So we're aiming for that 1,000 to 1,200 milligrams, depending on your age. We're going to want some vitamin D. We're going to start that early and continue that lifelong. Exercise, so regular exercise. If you take nothing else away from my talk today, this is a really nice thing to start thinking about how can we integrate this. We're going to stay away from things that are harmful to the bones. So smoking and alcohol, we didn't touch on very much here today, but they are incredibly harmful for the bones. Alcohol, we start to worry about huge amounts. So when we showed that FRAX risk calculator, you get a point if it's 3 or more alcoholic beverages per day. So usually quite a bit, but something to think about. Steroids wherever possible. So recognizing that there are some conditions where we need them, that's the only option that we have, but it's always worth the conversation to say, do we have any other therapies that would be better? We want to stay away from falls, so make sure that your home is set up really nicely here, that we don't have loose rugs and small dogs and tiny humans that are going to run into you, that are going to lead to falls. Know your family history. So unfortunately, many people don't know this because osteoporosis is something that we're starting to learn more and more about. And so many times people aren't sure, but they'll say, oh yeah, I had a grandmother who was quite hunched over. She probably had vertebral fractures. But we're particularly interested in parental hip fractures. So ask your parents. And at the end of the day, this is going to be a really long conversation. When I see patients for the first time, we spend 45 minutes together talking about all of these types of things. So we need to individualize. So where do I find more information? So I work at the David Hanley Osteoporosis Center. There's a very beautiful website that has a great section that's for patients. So there's a whole bunch about dietary calcium. There's some stuff about exercise. There's some description of the medications if that's where you're going. Osteoporosis Canada has a really fun section. So we introduced the concept of calculating how much calcium you have in your diet. They have a tool on their website where you can put in what you've eaten in the day and it tells you how much calcium you're getting. Keep in mind that the plant-based dairy products often have the same amount of calcium as well. So if you're vegetarian, lactose intolerant, soy milk, almond milk, all good. We use that fracture risk assessment tool. If you just Google FRAX, it's the first thing that comes up. International Osteoporosis Foundation is out of the States, but they have some really nice information there. And there's a one-page handout called Too Fit to Fracture that has some really nice basic information on it as well. So at this point, I would be delighted to take any questions.
Dr. Hinz, come on over and we'll do a little Q&A and get some of those questions answered. That was completely fascinating. I have never for a minute thought about osteoporosis in my life, but thanks now to your heads up.
Cheese and dumping.
Cheese, movement. Is Dr. Hinz' mic working? Are we good?
Can you hear me?
There we go. Cheese, movement, and vitamin D. Quick question. How do we know what our vitamin D levels? The labs hesitate to test vitamin D.
Yeah, and as they should. So like I said, in Canada, just where we're at in our latitude, people are going to be vitamin D deficient. And this is why the lab has actually made it a little bit harder for us to order it. There's no point in poking you to tell us what we already know. So the other reason why we don't routinely do a vitamin D level is that there's a lot of disagreement about what the optimal number is.
Okay.
So if it comes back at 65, 70, 75, what am I going to do with that? There are certain circumstances where we will do a vitamin D level. If you come to my clinic and I'm about to start you on some medications, that's appropriate. But for the people in the room who don't have other reasons to do that, you don't need a level because it's not going to change what we do. So just take your vitamin D.
Just take your vitamin D. How do you feel about weighted vests?
It's a really good question. So I get asked this all the time, and there's very little data on specific exercises, and I have looked. So I like ballet. So I did some very self-centered research to say, well, does ballet help your bones? Really not a lot out there. So
I can tell you it's not good for your toe bones.
not good for your toes, no, but everything else, good. Weighted vests are a thought. It's one of the weight-bearing exercises that we can do. If you've had vertebral fractures, I don't love it in that situation.
Sorry, everybody. It's probably someone calling to wish me happy birthday. Yeah, sorry.
There you go.
But I'm trying to keep an eye on the time, too, so I got my...
I would file that under the list of maybes, that it's not going to be one of those magical cures, but if you like your weighted vest, let's go walking. That sounds
And
good.
go walk on hard surfaces.
Yeah.
As opposed to?
Honestly, it doesn't matter. So we're trying to get some impact on those bones. So
Impact on the bones.
Your bones work under a use it or lose it type of system. So we see this in astronauts. When they go to space and they lose gravity, they lose just massive amounts of bone. And so we're trying to give that signal to our bones. So if you're able to do some impact, great. If you can walk on a hard surface, great. If your balance is poor and you're at risk of falls, well, then let's get you a recumbent bike. Let's do something like that.
Okay, good. Any questions for Dr. Hinz? We've got some folks out with microphones zipping down the stairs to you right now. And we've got questions over here. How many microphones have we got out there?
Testing? Oh, good. Okay.
Yeah.
Thank you. That was really great. So I'm a chiropractor. I'm also a Menopause Society certified practitioner.
Amazing.
So this is my jam.
Thank you for what you do.
Prevention. So I noticed today you didn't talk at all about premature menopause. So I feel like there's been a shift. So the Menopause Society, the Public Health Agency of Canada, the Osteoporosis Canada, they all recommend a DEXA scan if you have had, chemo-induced or premature menopause before the age of 35. My patients are being denied DEXA scans through their OBGYNs, through their medical doctors, fighting for them to have that opportunity. And I have a patient in mind who, due to a misunderstanding, did not continue with her HRT postmenopausal. She was 31 when she went through menopause. She's now 40, and she has incidental findings of low bone density in her sacrum on x-rays, and she's been denied now. What can we do with those patients, and am I misunderstanding? Should they not?
You are. So unfortunately, the Osteoporosis Canada guidelines still put that age criterion on there, and it comes back to that idea about what are we predicting. So bone density in a younger individual actually doesn't correlate very well with their risk. So yes, there are some other societies with those guidelines, but that's actually not what's recommended in the osteoporosis world. The other reason for that is if your number one risk is you don't have estrogen, well, let's give you back some estrogen. And once that's off the table, then your risk goes back to baseline. So we actually do not accept those referrals in the Osteoporosis Center. We have a letter that goes back because the recommendation is, well, if there's a fire, let's fix it. So let's get you on some estrogen. So
There's a fire, let's fix it. Yeah. Oh, yeah, I like the way you're thinking about that. That's a great answer. We got a question over here.
How do you know when you've had too much vitamin D or calcium? Are there signs and symptoms of toxicity that you can watch out for and then decrease your dose accordingly?
Yeah, absolutely. That's a really good question. So for calcium, we get things like constipation. You can feel extra thirsty. You can pee more than normal. We can get kidney stones. So those would be your biggest ones from that. And then the same thing with vitamin D. So if you're worried that you've been on these big doses for a long time, that would be one of those situations where a vitamin D
It
level
would be appropriate to test. test.
You got it. So that would be looking for something different. That's not a screening test. That would be to say, hey, here's someone who has potential toxicity. So that'd be a great conversation with your doctor.
But those symptoms you're talking about also just represent menopause
Unfortunately, yeah.
and aging.
Yeah.
So it is a fine line that we walk.
Yep.
Go ahead.
Hi, morning. It's similar to the question that she had asked over there. Do you think women should be having like a baseline DEXA when they hit menopause? No, waiting until, I know the recommendation is 65.
70.
70, so we're waiting till then, unless there's been like a bone attack or bone crisis.
You got it. So the reason for it is because when we come back to that idea of that risk spectrum, so where do you fall on it and when am I going to do something differently? And basically we know that one of the biggest risk factors for osteoporosis is age. And so in a younger person who has not had fractures, who doesn't have those conditions that we listed there, they're not going to be anywhere near that cut point to give you medication. So doing a bone density isn't going to change anything. Now, the caveat on that is that we do bone densities in 50-year-olds in certain situations. So if there are high-risk features, then we would consider doing it at that point. But this idea of a baseline, it comes back to that analogy of I want to pack for my trip now, I want to know what the weather is. That doesn't make any difference if you're going in 6 months, right? So the idea of a baseline isn't going to change what we're doing. I'm going to get the results back. They're going to say, oh, it's probably just a smidgy low, but not too bad. And I'm going to tell you cheese and jumping. So that's the reason why we don't do a baseline.
Cheese and jumping is what we're taking away from this one today. That estrogen, hey? Like she's a bitch when she leaves.
Powerful stuff. She gets angry when she's gone, hey?
Yeah. Okay. Let's do one more.
Oh, and love your shoes.
Thank you. Thank you for noticing.
Yeah.
I'm a fan. I'm 70. I'm a retired pediatric dentist, which means I put miles and miles and miles walking in the hospital. Having said that, I had twins in the 90s, and when a time where women are forbidden to have HRT. I am now 70, and my family doctor's refusing to give me HRT. I've had rib and foot fractures and osteoporotic episodes. I do all the dietary things. I do the weightlifting. I have discovered a place called ISOPHIT, ISOPHIT in Nolan Hills that does a 30-minute strength training class exclusively, which is amazing. Disclaimer, it has nothing to do with me. But my question...
So you're saying you're doing the right things and you feel like you're still not getting your concerns addressed?
I'm having, yes, and the family doctors are blanketly saying, you aren't eligible for HRT at 70.
Well, what is the difference for education for a family doctor versus a specialist, somebody like yourself? Is this a situation where she should pursue a referral?
No, actually. So your family doctor is right. So ultimately, we have to balance the risks and benefits. And I know how frustrating that is. But I'm not going to give you any individualized medical advice here today. But just as a general rule, we tend not to recommend hormone replacement therapy in people over the age of 60 or more than 10 years from the time of menopause. And this comes back to the Women's Health Initiative, which is the one that initially set us back, where we got really scared about it. But when they went back and looked at that data in more detail, what they found was that people who were closer to the time of menopause did really well with hormone replacement therapy, and people who were farther out, they actually did very badly. So your doctor doesn't want to hurt you. She doesn't want to give you things that are going to hurt your heart. They don't want to hurt you there. So the general recommendation is if you're more than 10 years from menopause over the age of 60, the harms probably outweigh the risks. And so it's worth talking about, well, what else in our toolbox would be the right fit for you?
And cheese and exercise.
Cheese and jumping in the meantime.
And cheese and jumping in the meantime.
Fibromyalgia and all, but I'm doing it.
Yeah, and you keep on doing it. I think we're going to wrap up with you, Dr. Hinz. If it's a quickie.
My family doctor, I asked him to attend today as an information continuing ed class. He refused because every family practitioner in the city is currently attending their provincial continuing education conference. So it would be nice to have more physicians in attendance.
I spoke to them yesterday. I got them. Don't you worry.
Thank you.
There you go.
Thank you.
Crisis averted. Dr. Hinz is on them. Thank you so much, Doctor.
for having me.
That was fantastic. Thank you so much.